So malaria has been there from ages, right from centuries. And this is how the first person who described malaria was, not described, was Hippocrates. And it's derived from mal-air, bad air. Okay, so this is some historical, this is a very important topic for your exam point of view. Please pay attention. So this was the history of malaria, for those who are interested. For us, we started 1955. We started the World Malaria Eradication Program using DDT. 1970, mosquitoes started the resistance to DDT. Okay, so the program failed. So this is another two persons. One is Lavin and one is Ronald Ross. So this is a Nobel Prize. Ronald Ross won it for his work in malaria, and also Alphonse Lavin won it for malaria also. Okay, so so female Anopheles mosquitoes transmit malaria. So if you look at the world map, it's not there in America, it's not there in Central Asia, it's there in South America, Africa, India, Indian subcontinent. So usually mosquitoes malaria is not transmitted about 2000 square meters, that is 2000 meters, that is maybe in Sikkim or some other places, doesn't occur. Nor does it occur with below 16 degrees or above 33 degrees. Okay. So it has 4 subgroups, of which the most dangerous one is Falciparum. Microbiology? Okay, so I'm not going into further parts of that. Plasmodium vivax, Plasmodium ovale, Plasmodium malariae and Plasmodium falciparum. Falciparum is the most dangerous. Okay, so this we will not skip all this. They will start with mosquito, bite of mosquito, sporocytes introduced. Then we have this cycle. Mosquitoes, then the sporocytes become schizons. They invade the liver and the red cells. I'm not going further into it. Life cycle of malaria. So this is the period of pre-erythrocytic cycle. For vivax it's 8 days, falciparum it's 6 days. On maturation, liver cells rupture and the schizons and monocytes are liberated. That is when the fever starts. Okay. So here is erythrocytic schizogony, which is basically trophocytes, schizons and monocytes occurring. So whenever the monocytes are released, that is the time when fever starts. So this is how it looks like. Plasmodium vivax, that is schizont data. Okay, which has got numerous nuclei. So this is the structure. So from microbiology podicho, ring form, double dotted trophocyte, early schizont, and finally we have female and male gametocyte. I am pretty sure that you have learned in microbiology, which is why I am not going to repeat it again. Okay. This is the trophocytes of falciparum. And we have some other characteristic features like Schiffner's dots, James dots, etc. Only of interest to microbiologists, not for common persons. Okay. So, these are some of the criteria of mosquitoes biting and things like that. So, you have gametocytes, macrogametocytes, microgametocytes. So, here what the basic thing is this. Parasite is sucked up and then the sporocytes develop in the oocyst, oocysts develop in the gut wall and sporocytes migrate to the salivary glands. This is what happens in the mosquito, not in man. Okay? So, sexual cycle is initiated in the humans by the formation of gametocytes, develops further in the female Anopheles mosquito, and then you have microgametocytes coming, and that's how it develops in the mosquito. Fertilization occurs when a microgametocyte becomes a macrogametocyte, and it's called, again you have a zygote, ookinete and oocyst. So this is the life cycle of Plasmodium. Mosquito bites the person, a skid lady. Trophocytes enter the liver cells, multiply, forming merocytes that burst out of liver cells here. Okay. And then the infected blood cells are there. Merocytes enter the red blood cells, forming new merocytes, develop into gametocytes. Then again, female Anopheles mosquito bites a human infected with Plasmodium, picks up gametocytes. Gametocytes develop again in the mosquito body, travel to salivary glands, and then again the cycle is continued. So this is the basic cycle of malaria transmission, mosquito cycle. First the blood is taken, sporocytes are taken, then it enters the liver, become merocytes. Merocytes enter RBC, multiply, then it bites, again the female Anopheles bites the human person, picks up the merocytes, picks up the gametocytes, and then sporocytes form, and then it goes into salivary glands of the mosquito again. So this is how what I told you just now. Will not go into that. So let's go to the clinical features of malaria. This is more important. What is the clinical feature of malaria? Any idea? What is the clinical feature of malaria? Bolo. Apart from fever. What is the clinical feature of malaria? Huh?
Chills and rigor.
Chills and, okay. What is the chill and what is the rigor? What is the chill and what is the rigor? And what's the difference? Bolo. Say it correctly. Chill and rigor. What is chill and what is rigor? Chill is when they say, when the bed is shaking, it's called a chill. When the teeth are shaking, it's called rigor. That's what a textbook says. Anyway, okay, so you have fever and chill and rigor. Then what else? Fever and shivering. Shivering, okay. Shivering is the characteristics. Then general condition, unwell, headache, nausea, vomiting, all these can occur. These are due to bursting of cells and release of the other things. Okay. So infection occurs when an Anopheles mosquito feeds on an individual, releasing sporocytes. So what are clinical features? Apart from fever, you can have enlarged spleen, you can have sweating, anemia, irritability, coma, retinal hemorrhage, algid malaria, respiratory distress syndrome. Now we have a term malignant malaria, cerebral malaria, etc., all one and the same due to falciparum infection. It can affect the central nervous system, causing loss of consciousness, convulsions, paralysis, okay, even death. Cerebral malaria, hyperpyrexia, coma, paralysis, and the brain appears congested. Same thing in it's also called Blackwater fever. In large number of RBC are destroyed and the urine becomes black. That's why it's called Blackwater fever. So, how long malaria infection can last in man? Without treatment, it will terminate less than 1 year. But there can be relapses in up to 5 years for Vivax and Ovel. In Plasmodium malaria, it can last for 40 years. Okay. So, it means that once you have malaria, it doesn't mean you will not have malaria again next year or the year after that. You can have it. It can also, why is falciparum dangerous? Because of the above mentioned reasons. Cerebral malaria, malaria hyperpyrexia, GI disorders, algid malaria, Blackwater fever. All these can, Plasmodium malaria can cause nephrotic syndrome. And another term, Pernicious malaria. So don't get confused by all these terms. Any such term in front of malaria means usually falciparum malaria, the dangerous variety. So usually chill for 15 minutes, chills for 15 minutes to 1 hour. And then there's sweating, nausea, vomiting, and stage 2, very high fever. And after that, he starts sweating. Okay. So first there's chill, then there's high fever, then there's sweating. Hepatomegaly, splenomegaly, normocytic anemia. Lab diagnosis is earlier done through thick and thin smears. Now we have rapid kits, but still for your exam, have you examined a malaria slide? Dekhicho? Acha, ठीक है. Shabbai dekhicho? Shabbai dekhicho. Okay. So this is how you test your blood. Okay, when you're testing it, you thin or thick fluid. This is a thick smear. This is a thick smear of the malaria, and the other one is a thin smear. Thick smear looks like this, and thin. This is the appearance of thick and thin. Okay, two different things. Both are required actually. So it is stained by what is called a Jimsa stain, and this is the gold standard for lab confirmation of malaria. Now you have rapid diagnostic test RDTD, which gives the report fast. You don't have to wait for somebody to see it very carefully. Okay. So drug of choice is still chloroquine, and it's 1.5 grams of chloroquine. What is the side effect of chloroquine? What is the side effect of chloroquine? Bolo. Major side effect of chloroquine. Before that, caused malaria. How many people have had malaria? Nobody. Very good. You had malaria. Nobody's had malaria. What is the side effect of chloroquine? Side effect of chloroquine. Before that. Somebody who's had malaria who has taken a medicine, no. You feel like vomiting. That's the first thing. Okay. So 1.8 grams of chloroquine over 4 days. Then again there is resistance to chloroquine. So what do? You have newer drugs, but still we need quinine, etc. Primaquine is given, but what is the danger of primaquine? Primaquine cannot be given to people with G6PD deficiency. Can you name a community which has got G6PD deficiency? No, not so that. G6PD deficiency at a community in India. A very famous, well-known community which has got G6PD deficiency. Small community. Huh? Well, I heard the answer of somebody. Yes, a Parsi community. They have G6PD deficiency. They are very brilliant, but the numbers are dropping. They have, because they cannot marry within their community, they have to marry within the community. So they have G6PD deficiency. Okay, this is just something separate. So, drug resistance only, give quinine, or you can give quinine doxycycline, or quinine plus clindamycin. Mefloquine, halofentanil also can be given. Okay. So, how do you control malaria? Malaria, as I said, has been there for centuries. But how do you control it? Improvements in health and hygiene, use of mosquito nets, clothing with sleeves, long trousers, use of mosquito repellents. We had a lot of changes in the malaria program, and at the end of the day, the government said, we cannot have so many programs. All these things have to be worked in one program. What is the program? National Vector-Borne Disease Control Program, which has 6 diseases. Which are those? Chikungunya, Zika, Dengue, West Nile fever, malaria, and yellow fever. Okay. So, this was the National Vector-Borne Disease Control Program, has replaced the old malaria programs. Okay. So, very big program. It's an umbrella program for prevention, not only malaria but other diseases also. So, it was launched in 2003-04. The diseases include malaria, JE, filaria, Kala-Azar, Dengue, and chikungunya. So, this was the aim, some of the aims of the vector-borne disease control program. Reduce mortality on account of malaria, dengue, and JE, elimination of Kala-Azar, elimination of lymphatic filariasis. This is a question which is often asked in the exam, which was asked even this time. What is what is integrated vector management, what is NVBDCP. So this is it, early disease management, integrated vector management, supportive interventions. In the disease management, you have early case detection, complete treatment, referral service, epidemic preparedness, rapid response. Integrated vector management is a big thing. Indoor residual spray, insecticide treated nets, ITN, larvivorous fish, source reduction. And supportive interventions like behavior change communication, public-private partnership, IEC, HRD, all this stuff. Okay. So, this is once again the recap of the same thing. So, the first thing is the early case detection, EDPT. Again, a short note, what is EDPT? Early detection and prompt treatment. So, for that you need chloroquine. You need chloroquine to be given freely available. And how to make something freely available? How to make something freely available? Suppose you want to get a medicine and you have to go to Bolpur for that. That medicine is not available here, you have to go to Bolpur. Kya hai? Common medicine. It's difficult, isn't it? So you need to have some access to it very fast. So for that, we have this drug distribution center and fever treatment depots at every village. Okay. Then in indoor residual spray with insecticides, chemical larvicides like abate, aerosol spray, marathon and fogging. Then biological control, use larvivorous fish like guppy, gambusia, and personal prophylactic measures, use of mosquito repellents, creams, liquids, coils, mats, screening of the houses with mosquito with wire mesh, use of bed nets treated with insecticides. Then community participation. Why is community participation essential? Why do you need the community? Why do you need the community for helping you out? Bola. Why do you need the community? Why do you need the community's help in this program? What will happen if the community doesn't help you? Any idea? Bola. Why is community important? Because they only can help you source reduction and filling up breeding places, coverage of stored water. All these, you need the intervention of the community. If the community resists you, you cannot do anything. Channelization of breeding source. Then evaluation and monitoring of the program by state level officers, etc. So these are some of the milestones which were achieved. Okay. So 1953, 1953, we had 75 million deaths due to malaria. Sorry, 0.75. 1958, they said, let us make malaria control program, eradication program. What happened was the cases reduced. But again, 70s decreased. Then they brought this modified plan of operation, then MCP, then finally in 1999, they named it National Anti-Malaria Program. 2002, they made this final program, National Vector-Borne Disease Control Program. So a lot of funds have come in also, World Bank and all, but the long and short of it is that the malaria program has changed a lot in the years. And we are not talking much about malaria at the moment. Okay. So, we've had a lot of changes, again, milestones. So, this fever treatment depots, what are they? They're basically places where you get chloroquine. It can be in a sub-center, it can be the house of a health worker, or put in a remote area particularly, say hill area in, say, Sikkim or some other place, or Darjeeling for that matter. So, that person is given training how to give the medicines. You have 10 medicines here, but that fever treatment depot holder, he or she should be told how to give the medicine. 1 tablet twice daily, 2 tablets thrice daily. That instruction will be given clearly. Okay. And also collection of blood smears, administration of presumptive treatment, impregnation of blood nets, promotion of larvae, virus, fish, etc. Then you have drug distribution center. If here there is no, the drug distribution do not take blood slides, but they administer drugs. FTD they take the blood also. Here there is no blood taken, but you are giving the medicines. Okay. So here also volunteers identified, and they should have trainings and promotion of other activities like blood bed nets, larvae, virus, fish, source reduction, etc. So this is a mission to reduce the morbidity and mortality. And they're contributing to health and alleviation of poverty. Screening all fever cases by rapid diagnostic test. Wherever there's a chance, test for malaria. And treating all falciparum cases with full course of ACT. ACT is artemisinin combined therapy. Okay. Usually artemisinin is a new drug combined with sulfur-dioxane and pyrimethamine and primaquine. Okay. And then equipping all health institutions with microscopy facility and RDT, and strengthening all district and subdivision hospitals as per Indian public health standards. So this is some of the other terms which you should know. One is annual blood examination rate, which should be over 10%. That means at least 10% of the population should be checked for malaria, and the 80% should be get protection by insecticide treated nets, okay, or long lasting insecticide nets. So these are some various strategies which, this is another term which you should know, API, annual parasite index. So where API is less than 1, it's not a problem, but where API is more than 1, it means the mosquito density is quite high. Where it is less than 1, you just do biological control, desilting, deweeding, etc. Okay, but between 1 and 2, you need more this thing, you need active surveillance. What is active surveillance? What is surveillance first of all? What is surveillance? 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 Huh? No, what is surveillance? Surveillance of director point. What is surveillance? What is surveillance? Just general term, what is surveillance? Surveillance means to keep a watch on. Now what is active surveillance? What is active surveillance in this case? Direct personal kache jawa. Acha thik hai. আর তাহলে অ্যাক্টিভ সার্ভেলেন্স যদি হয়, প্যাসিভ সার্ভেলেন্স কি হয়? হ্যাঁ, ওকে, ডাটা থেকে, না না, নট ডাটা। বেসিক্যালি ইফ ইউ সামবডি ইজ গট, তোমার গ্রামে অনেকজনের জ্বর আছে, রাইট? সো অ্যাক্টিভ সার্ভেলেন্স মিনস তুমি ঘর ঘরে জিজ্ঞেস করবে কার বাড়িতে জ্বর আছে। প্যাসিভ সার্ভেলেন্স অন দ্য আদার হ্যান্ড মিনস ইফ দে কাম টু ইউ, তোমরা দেখবে। ওকে, now it means that the person may come to you, the person may go to Sian hospital, may go to some other hospital. That is passive surveillance. Active means you are going to all the houses and finding out. So where API is more than 2, you have to go for active surveillance. And when it's more than 2 to 5, then you have to give also insecticide nets, 2 per household of 5 members. Plus, and for API above 5, 2 rounds of spraying, priority distribution of nets, 1 round of IRS, indoor residual spraying also before it start transfer. So API above 5 means it's a very dangerous thing where you can get malaria like anything. Okay. So the problems of malaria, deaths. This is a figure, malaria, the total malaria cases are deaths. Okay. So of the total malaria cases, the falciparum is this violet. So the number of cases are on a decline. So this is what I told you about the malaria changes in the malaria program. Started as malaria control program, then eradication program, then there was a resurgence of malaria. Case Badlo. Then they started, they said insecticide resistance. Then they changed all these names. National Anti-Malaria Program, and all these things. Okay. So this is the plan which we already discussed. That is case detection, active and passive, early diagnosis and treatment. Then integrated vector management, indoor residual spray, insecticide treated bed nets, long lasting insecticide treated nets, anti-larval measures including source reduction, supportive interventions, capacity building, intersectoral coordination, monitoring evaluation, operational research and applied field research, epidemic preparedness and early response. So this is what we talked about. So thick film and thin film, this is how it looks like. Microbiology, rapid diagnostic tests also there. So if you have a positive case, this is how you treat the patient. You start on the medicine straight away. Okay. Clinically suspected case, this is the algorithm. So if it's Plasmodium vivax, you give chloroquine for 3 days plus primaquine for 14 days. Falciparum, you give ACT, that is artesunate combined therapy, and primaquine single dose. Okay. If it is available within 24 hours. If it is not available within 24 hours, then you have to do a RDD. So chemoprophylaxis. Lot of questions people ask, why should we need chemoprophylaxis? Suppose you are going to go to an endemic area. Suppose you are going to, anybody from Orissa? Orissa? No, anybody from Orissa? Nobody from Orissa here. Is there anybody from Orissa? Who's there? Nobody has come. Huh? Nobody anyway. Huh? Nobody from Orissa. Acha, okay. Suppose you're going to stay in a place like Simlipal. Simlipal, you've heard Simlipal, na? Orissa. So there, if you're going to there, you need to take short-term prophylaxis with doxycycline 2 days before travel and continue for 4 weeks after leaving the malaria area. Okay. You're going for a 1 month or some work that side. This is the chemoprophylaxis. Long-term chemoprophylaxis, pefloquine. Whenever foreigners come to India for work, they get scared about malaria. So they come with all these precautions and chemoprophylaxis and all this stuff. Okay. So integrated vector management, IRS, insecticide treated bed nets, long lasting insecticidal nets. And these are the breeding habits of Anopheles mosquito. I'm sure you've seen this somewhere. Okay. So IRS is an important intervention, indoor residual spraying to kill mosquitoes. And here you have to change the insecticides. Selection of insecticides is also important because the resistance builds up very fast. So you need DDT, organophosphorus, synthetic pyrethroids. Okay. How many of you sleep with bed nets? How many of you use bed nets while sleeping? Huh? How many of you? Moshari kothojan gumo? Akjan. Only 1%. Okay. Anyway, so long lasting net is a mosquito net that has been treated by dipping in a WHO recommended insecticide. Okay. Now, I'll give you it has shown on. I'll give you a real story which happened in Jharkhand 10 years back. In Jharkhand, I was posted in Jharkhand, and the then Chief Minister happened to be from the same place, Chaibasa, Mr. Madhu Koda. So that time, suddenly, one day I came there and the chief civil surgeon, he told me, Doctor sir, please, can we go out somewhere? I said, what happened? The Chief Minister's parents have got malaria. Chief Minister's parents have got cerebral malaria and we have to transfer them to Ranchi. Chalo, let's go. So I also went with him in the car. And my driver was saying, afterwards, he said, during the car only, he said, sir, but how did he get malaria? I said, how did he get malaria? How do I know? कैसे malaria होगा उसको? बोला सर हम लोग तो सब तो इसको net दिया था because of the distribution of nets by the government. And my driver also got the net. So I said, okay, ठीक है भाई. We went there, big crowd gathered, all the Patrakar, Shavais, Then finally the old man and the chief minister's father and mother, they put in the ambulance, taken there. So after they went, I told the CS, sir, मच्छरदानी का क्या हुआ? मच्छर, then he also said, हाँ मच्छरदानी तो हम लोग दिया था यहाँ पे, क्या हुआ? So he asked the next person, sir एक मिनट, चलिए sir दिखाते हैं. So we went to we walked a bit, he showed us a pond. So over there all these people were catching fish using the mosquito nets. They tied all the mosquito nets and they were catching fish. देखिए sir, यहाँ मछली पकड़ रहा है, मच्छरदानी से मछली पकड़ रहा है. This is what happened. So that is what happens when you have the wrong sort of thing. Mind you, the true incident which happened. It's not exaggeration. They were catching fish with the mosquito nets. वो पूरे माछ धर चले. Okay, so this is a bit of thing. Anti-larval measures, environmental control, biological control, genetic control, chemical control, all this. Biological control, guppy and gambusia. Bacteriological control by Bacillus thuringiensis, Bacillus furiosus and other biological agents. So this is again urban malaria scheme. Hello. Oh. Urban malaria scheme. Vector control, anti-larval methods, larvivorous fish, aerosol spray, etc. So this is if there is outbreak of malaria, unfortunately we don't have much outbreaks like this. So this is it. Active surveillance, passive surveillance, central surveillance, and it's also under IDSP. Suspected case, probable case, confirmed case. Okay. So integration with ASHA workers, other village health guides, etc. is part of the NRHM. And the same things. We have support from the World Bank for this. Okay. So I don't think we'll be able to eradicate malaria. We will be able to control it. That's about all. Okay. So malaria burden can be controlled, vector control, malarial vaccine. Malarial vaccine is being developed but still not yet come out. So Kala-Azar. Now this is a disease which is probably the only disease which has got its name from India. The only disease in the world which has got its name from India. So it's also called Kala-Azar, black fever, sandfly disease, dum-dum fever and espundia. So this is how a Kala-Azar patient used to look like in the earlier days. Okay, he looked like some mummy or something of sort. And from the exam point of view, this was a Kala-Azar patient. Almost every student in pediatrics would get this, or even in medicine or surgery, a case of Hepato-Splenomegaly. Today we don't have that many cases, but this is a classical case, Hepato-Splenomegaly, in the case of Kala-Azar. Then you have the other things, the various skin manifestations of Kala-Azar. This is the fly which causes sandfly. Okay, this is a microscopic form. This is a sore as part of the sandfly. Amastigotes, promastigotes. Now this is occurs in 5 continents, but India or rather Asia is at the maximum risk. And again this part West Bengal, Jharkhand, Bihar, etc. But now there has been a decreasing trend past few years. So this is the first history of the parasite. First description in English was in 1756. Then 1903, Leishman identified the parasite. Donovan also identified the parasite. So that's why it's called Donovanensis and Leishmaniasis. So you have different types: visceral, cutaneous, diffuse cutaneous, mucocutaneous, and PKLD. The PKDL, endemic to India and Sudan. Here you have irregular bouts of fever. Weight loss, swelling of the liver and spleen, liver, and anemia. Skin ulcers on the exposed part of the face. This is a classic thing, skin ulcers. That's why it said Kala-Azar. Okay. And also on the mucous membrane of the nose, mouth, and throat cavities. It's called aspenda. So this is transmitted by the bite of female phlebotomous sandflies. It injects the infective stage during blood meals. And then they transform into mastigotes. And here they multiply and migrate to the proboscis. Here what is to be done? We had such a big problem in the past. So here you reduce the vector population by indoor residual insecticides, early diagnosis and treatment, health education program. Again, same thing, IRS what was done was malaria, then also in spraying of insecticides and using of bed nets, and detect epidemics and to provide early diagnosis. Early diagnosis by this LD bodies, ELISA test, LDI test, and PCR. Treatment this is a treatment: sodium antimony gluconate, pentamidine, amphotericin, miltefosine. Okay. So these are the alternative regimes. Vector control, these are the methods for that. If it is resistant to DDT, you can give VHC. So once again, it's a group of protozoal disease which has a broad spectrum: Kala-Azar, cutaneous leishmaniasis, mucocutaneous leishmaniasis, then other things also there. Okay, so if you look at the visceral leishmaniasis, again Africa and Asia, cutaneous also Asia and Africa, and majority are in India. So India, Assam, West Bengal, Bihar, eastern districts of Tamil Nadu, UP, Sikkim, and lesser extent Tamil Nadu. Okay. So it is endemic in 52 districts of Bihar, Jharkhand, West Bengal, and UP. These are the latest figures. So this is the sandfly. Leishmania donovani is the only parasite. And here it is person to person by the bite of the female sandfly. It can also occur by crushing the fly. Suppose you have fly and you crush it. In that case also you can get it, and also blood transfusion and contaminated syringes and needles. So what are signs and symptoms? Fever, abdominal pain, loss of appetite, pallor, weight loss, progressive emaciation, weakness. The skin shows dryness, greyish discoloration, which is why the name Kala-Azar comes. Okay. As I told you, the only disease which has got its name from India, Kala-Azar, which means black fever. So this is the exact picture. Splenomegaly. Okay, doctor. See the picture. Tell me what you find. What do you find? Batao. Bolo. Ki dekhte ho achha? No, forget it. What do you see in that? You tell me now. Enlarged abdomen, only abdomen. Something specific is there in the picture. Everything is given there. What is written there? Splenomegaly, hepatomegaly, lymphadenopathy, anemia. All this is a classical picture. In every pediatrics exam, you would get a case like this. Okay. And the other thing is cutaneous Kala-Azar. it is restricted to areas like fly bites, where there are fly bites, like for example the ears. Okay. So these are the various tests. Aldehyde test is the common test which is demonstration of the parasite is the only way to find out. Control the reservoir, fly control, treatment of the cases, and personal prophylaxis. So here you have again antimony, pentamidine, amphotericin, miltefosine. These are the drugs which are used for Kala-Azar. Sandfly control, insecticide spraying at height of 6 feet above sea level, above floor level. Okay, and personal prophylaxis. So here indoors residual spraying twice, annual major activity. And this is my last slide. This is a person whose name is associated with this, though he did not get what he was supposed to get. He's an Indian obviously, associated with this topic. Can you identify it? The person who said the answer, please chip it up. Yes, Dr. UN Brahmachari, who worked in Kala-Azar, he brought out the first drug against Kala-Azar, and that time that disease was called Burdwan fever. Actually, it started in this area. And then at the same time when Donovan found out Leishmaniasis, and this Dr. Brahmachari, he discovered that a cheaper drug is there. He discovered it, and he even was nominated for Nobel Prize in Medicine, but he didn't get it. And today in Kolkata, one street is named after him. Tell me where it is. One street is named after him in Kolkata, which has a major hospital over there. Anybody from Calcutta? You're from Calcutta. You're from Kolkata, no? Name a street in Kolkata which is named after him. Area. You don't live in Kolkata. Anybody from Kolkata? Nobody. UN Brahmachari Street to UN Brahmachari Street. It is actually the new name of Loudon Street. That place is where, or rather Minto Park, next to Bellevue Clinic. Okay. So that is called UN Brahmachari Street. Okay. So anyway, so this is a person who worked a lot in this. Thank you very much.